Yeah. It's going like this.
Good evening, participants and delegates. Thank you for joining Shield Connect. And today we're going to speak on a topic menopause and its management. And the speaker for the day is Dr. Dipti Goswami. So before we start with the session, let me share my screen, and I will take a few moments about talking about the Shield Connect page and our speaker for the day. So 1 minute. So this is our page, shieldconnect.in. So you can go through this page, and this is 5 awards that we have won during this 2020 to 2022 in women's health technology solution categories. And we have different sections available in our page. So first is the blog section, where you can find all the top blogs written by our experts and speakers who are connected with Shield Connect. Then the second section is the webinar section. So we have upcoming webinars and past webinars. So in upcoming webinars, you can see all the webinars that are going to be conducted on our page. So if you click on today's topic, that is like menopausal management by Dr. Dipti Goswami, if you click on see more, you just have to register with your email ID and you can see webinar on this page. And here you have to just comment. This is the comment section where you can post your queries and feedback. So at the end of the webinar, we can have a Q&A session with our speaker for the day. And then we have past webinar section. You can find all the webinars that have been conducted on our page till now. Then we have awareness pages like PCOS awareness page, menopause awareness page, GDM, COVID, thyroid. So like if you check on menopause awareness page, you can find all the topics like the blogs and videos related to menopause on this page. Similarly, we have different pages available for different categories. Then we have our leader page, which you can find all the key opinion leaders. Like you can also check for the profile of Dr. Dipti Goswami in this page in detail. Okay, so those who are connected with Shield Connect, you can find their profiles here also. Then we have a special page like Hypertension Day, Mother's Day, Safe Motherhood Day. So if you click on any of the page like hypertension, you will find all the video regarding hypertension day. So this is our page Shield Connect. And now let me talk about our today's webinar, Menopausal Management, and it is an educational initiative sponsored by Estrogen 100, AppCord, and mTOR 800. So Dr. Dipti Goswami, ma'am, is a senior consultant in obstetric and gynecological section from Dispur Polyclinic and Hospital. And ma'am is also secretary of Guwahati Obstetric and Gynecological Society. So I welcome you, ma'am, on our platform for today's webinar. And I will hand over the session to you, ma'am. Thank you.
Thank you, Shilkane, and thank you, Doctor. So today I'll be talking on, just give me a second.
Yes, ma'am. We can see your slide.
Yeah. So today I'll be talking about a very important topic, that is the menopause and its management. So we all are aware what is menopause. It is a normal natural event which is defined as a final menstrual period confirmed after 1 year of no menstrual bleeding. And it represents the permanent cessation of menses resulting from loss of ovarian follicular function, usually due to aging. The average age in a spontaneous natural cycle is about 15 years of age, and but the menopause may occur prematurely, either from medical intervention like bilateral oophorectomy, chemotherapy, at any time from impaired ovarian function. And we have also terms like premature ovarian failure or premature ovarian insufficiency. Disha, stop. Now coming to the menopause terminology. So this is the straw staging system of menopause terminology. And this terminology, the straw staging system of terminology, it divided the adult female life into three broad phases. That is the reproductive phase, the menopause transition, that is the perimenopausal phase, and the postmenopausal phase. And as you could see, actually this was the staging of reproductive aging workshop, which was proposed in 2001, and it divided the cycles according to the menstrual cycles, the endocrine levels, and you could see in this chart the straw staging system that in the reproductive age group, the menstrual cycle was variable to regular, and the endocrine levels, if we do the endocrine levels, then we have a normal FSH, or it could be the raised FSH in the second part. The stages, the -5, -4, -3. So then we have this menopause transition, that is the perimenopausal, the transition phase, where the cycle could be variable cycle length, which could be more than 7 days or more than 7 days, different from the normal cycle, or there could be more than or equal to 2 skip cycles, and an interval between this cycle could be more than or equal to 60 days. And we could find the FSH is raised and AMH also starts decreasing. And then we have the postmenopausal age, where there is no menstrual cycle and the FSH is raised and AMH is significantly less. So if we see that while the life expectancy has increased, the age at menopause has remained constant. This is a beautiful chart which shows that the years, this is the Campbell chart, that is the management of menopause and postmenopausal years. So you could see that the chart shows that the age at the menopause, it has remained constant, that is around 50 years, but the life expectancy has increased. So that gives you a view that why the management of menopause becomes very important. Why? Since the life expectancy has increased, the women in the perimenopausal and menopausal age group, they demand more care, more emotional, psychological, the physical care they require as the life expectancy has increased. So if we do the serum hormone levels at the menopause, we find that the estrogens, the circulating level of the estrogen, it significantly decreases. The ratio of estrogen to androgen, it decreases. There is a decrease in the sex hormone binding globulin secretion. And there is a increase in the peripheral aromatization of dehydroepiandrosterone to estrone. And there is a reversal of the ratio of estradiol to estrone. And there is no significant change in the testosterone level. So this is the chart which shows that where are the estrogen receptors located in the body. In fact, you'll come to know that estrogen receptors are there in almost every part of the body, from head, brain, breasts, eye, genitourinary tract, heart and blood vessels, liver, ovaries, skeleton, skin and hair. So that is why as the estrogen levels start decreasing, a woman experiences the changes not only from the skin to hair to all the organs of the body, the bones, including the bones, the skeletal tissues, the genitourinary tract, because of the receptors which are present all over the body. So estrogen receptors are been identified are the two types of estrogen receptor, as we know, is the minus alpha and the beta. So estrogen receptor distribution, alpha and beta receptors, they are present both in the central nervous system, in the blood vessels, bone, heart, breast, ovary, uterus and testes and prostate. Alpha receptors basically in the liver, beta receptors in the lungs, kidney, bladder and intestine. So what are the effects of estrogen at various sites in the body? So estrogen has both complex beneficial and deleterious effects on the body. So if we see on the bone, so there is increased deposits of calcium into the bone if the estrogen stimulation is there. And the clinical effect is that if we supplement estrogen, then there is an increased bone density. And if the estrogen decreases, then it leads to osteoporosis. Similarly, in the brain, the estrogen effect of estrogen stimulation is that it blocks the release of ovarian estrogen. The clinical effect is none, but because of the depletion of estrogen in the body, if we do not supplement estrogen, then there would be hot flushes, the sleep disorders, the mood changes, problem is memory, that is the Alzheimer's. Then again, in breast, we know that estrogen stimulates the growth of breast tissue. So the clinical effects are bigger breast, but as well, if we keep on supplementing the women with unopposed estrogen, then there is increased risk of breast cancer, increased sensitivity of the breast, and increased sensitivity of the breast. And if there is what happens when there is an absence of stimulation, we have the smaller breast. Similarly, in the blood clotting, where there is increased risk of blood clots with the stimulatory effect of estrogen, and there is no change in the clotting if there is absence of stimulation. Then blood fats, there is increase in the HDL, but cholesterol and LDL both decreases. And if in the absence of stimulation, there is the HDL decreases, whereas LDL and cholesterol, it increases. So skin, again, because of estrogen stimulation, there is increased fat deposits in the skin. The skin, the clinical effect is that we get softer skin, but as soon as the estrogen starts depleting, we get a thinner skin. Then the skin becomes very dry and you get the liver spots. In uterus, because of the increased stimulation, you get increased endometrial hyperplasia. The endometrial thickness, it increases, lining increases. You get a heavier cycles and increased risk of endometrial cancer. And if there is an absence of stimulation, then the patient remains amenorrheic. And in the vagina, there is increased thickening of the skin, better blood supply to the vaginal tissues. And the effect is that there is an increased vaginal discharge and there is a feeling of pelvic congestion. But in the absence of stimulation, there is dryness, vaginal infections, there's dyspareunia, incontinence of urine, and pelvic weakness. So it has been found that the estrogen loss and the manifestations of health risks over the time. So the estrogen, as we know, it's the estrogen loss, it starts slowly during the perimenopausal stage, and then it slowly it further decreases and decreases, and then again in the later stages of your life, the estrogen depletion becomes increased, and the health risks also increases and there are short-term symptoms and a long-term symptoms, and this would be depicted in the next chart. That if you could see that in this slide, we could see that initially the hot flushes, it remains like if it starts as soon as the estrogen loss it starts or estrogen depletion starts, the patient starts feeling that hot flushes. And the mood, sleep, and the acute cognitive changes also, they start in the age group, say around 50 to 55 years. Initially it starts and these symptoms are more. And then again, this urogenital symptoms and skin changes, they remain. Initially it starts and they remain, this urogenital symptoms and skin changes. Cardiovascular symptoms, the osteoporosis and cognitive this decline, it starts slowly and then it remains in the later half of the life, it remains more prominent. So as the age advances, lay around 65, 70, 75, the cognitive decline, it becomes more prominent. Cardiovascular disease, as we can see, that it from 55 plus age group, the cardiovascular disease, the risk, it increases. Again, 60 plus, the osteoporotic changes become more prominent. So what is the physiology behind this menopausal symptoms? As we all know that each ovary has a certain number of oocytes from birth, which steadily decreases until we are approximately 50 years old, when the stock becomes exhausted. And during the perimenopause age, the follicular activity phase, estrogen levels decrease and pituitary gland produces increased amount of LH and FSH due to negative feedback. The cycle then becomes anovulatory, follicular development stops, and the endometrium is no longer stimulated and amenorrhea occurs. So a natural menopause occurs because as you get older, your ovaries stop producing eggs and make less of a male hormone, that is the estrogen, and the symptoms that are experienced by women is because of the low levels of estrogen, and it signals the end of the fertile phase of the women's life. So this is a picture which shows what a woman experiences when she starts having the depletion of the estrogen starts declining, and there is a transition from the perimenopausal age group to the menopausal age group. She starts having this headache, hot flushes. The hair becomes very thin and it loses luster. The teeth loosen and gums recede. The breasts droop and flatten out. The nipples become smaller and flatten. The increased risk of cardiovascular diseases. Patients experience backaches. The skin and mucous membranes, they become very dry. The skin develops a rough texture. The abdomen loses some muscle tone. The body and the pubic hair becomes thicker and darker. Then we have the urogenital symptoms with which patients usually visit OPD, like the patients complain of stress and urge incontinence, and also vaginal dryness, itching and shrinking. And there is the symptoms of the osteoporosis, like they lose the bone mass, loss of bone mass, and they become more fragile, and the patients become more prone for fracture. So the symptoms of menopause in natural history, the menstrual irregularity, it starts and increase from 2 years prior to the FMP and peak at 1 year following it and return to normal after 5 years. And it varies widely. There is menstrual irregularity, as I have already discussed, that what the patients experience are the hot flushes, sweats, sleep disturbances, vaginal dryness, urinary symptoms, mood changes, loss of libido, osteoporosis, and cardiovascular disease and stroke risk increase. And usually the menopausal symptoms are usually self-limiting, usually last between 2 to 5 years and may last longer in some patients and some women. And the menstrual irregularity, it depends. In some patients, the cycle length may shorten, some may lengthen, and often they become more heavy. Hot flushes is nothing, but there is a sudden feeling of heat in the upper body spreading upwards and downwards with patchy flushing of the skin followed by palpitations and sweating, and usually lasts for a few minutes. The women may experience sleep disturbances, often due to night sweats, which could lead to irritability problems with short-term memory and concentration, and vaginal symptoms such as discomfort, dryness, dyspareunia, and recurrent UTIs, and symptoms of atrophy may appear up to 10 years after the last period. Now, coming to the very important topic, that what is premature menopause? So the premature menopause is defined as the menopause which occurs before the age of 45, and the causes are like primary ovarian failure. It could be surgical induced menopause. It could be radiotherapy or chemotherapy induced, and it could be linked to the smoking, low socioeconomic groups, BMI. Then the family history is very important. Then any women who are less than 40 years of age, if they have this premature, you must be referred, because they need they are the candidates for the hormone replacement therapy to prevent the osteoporosis. And we have to stop this HRT in these patients once they reach the normal age of menopause, that is the 50. And primary ovarian failure may occur at any age, and usually no cause is found, and it could be linked to the chromosomal abnormalities or autoimmune disease, or it could be because of some enzyme deficiency. And it affects 1% of women age less than 40 years and 0.01% if less than 30 years. 5 to 15% of women have been found may retain intermittent ovarian function for years, and spontaneous ovulation and pregnancy are possible in some 5 to 15% of women with primary ovarian failure. Now, coming to the management of menopause, so these are the 4 pillars under which we can manage the menopause. That is, number 1 is the reassurance, number 2 is the education and lifestyle changes, number 3 is the HRT, that is the hormone replacement therapy, and number 4 is the alternatives. What are the lifestyle changes that are required is that, as we all know, that most of the women, they experience the hot flushes and night sweats, and it has been found that if we do regular exercise, if they are advised for lighter clothing, to sleep in the cooler room, and they manage the stress well, and if they could avoid triggers like spicy food, caffeine, alcohol, and smoking, so the hot flushes and night sweats could be relatively decreased in some of the women. So So these women, as they experience sleep disturbances, it have been found that if they maintain a regular routine and avoid late exercise in the day, then it could be somehow decrease. Mood and anxiety also requires relaxation and exercises and regular exercise and adequate sleep. And again, cognitive symptoms, they require adequate sleep and regular exercise. So the governing principles are that HRT should be a part of overall strategy, including lifestyle recommendation, which means that diet, exercise, stopping of alcohol and smoking, and or the safe levels of alcohol consumption for maintaining the health of peri and postmenopausal women. And it should not be indicated without a clear indication for its use, that is significant symptoms of physical effects of estrogen deficiency, then only you should prescribe HRT. Postmenopausal HRT, it cannot be a single regimen to be given to a standard woman. It has to be individualized and tailor made according to the symptoms and need for prevention, as well as a personal and family history. Then the relevant investigations and women's preferences and expectations must be taken into consideration. And there is no reason to place mandatory limitations on the duration of HRT. Whether or not to continue the therapy should be decided at the discretion of well-informed women and her health professional, depending upon what goals we want to achieve and the objective estimation of ongoing benefits and risks. And dosage should be titrated to the lowest effective dose so that we have a least side effects or none side effects. And low doses of HRT that have been used previously may reduce symptoms sufficiently and maintain quality of life for many women. So the counseling is very important. So women taking a HRT should be at least have an annual consultation, which will include a physical examination, update of medical and family history, the relevant laboratory and imaging investigations, a discussion on the lifestyle and strategies to prevent or reduce the chronic disease. So indications of HRT is that the number one is the relief of menopausal symptoms. Number two is to prevent osteoporosis, and number three to maintain the quality of life in menopausal women. So the special group of women to whom HRT should be prescribed is the premature ovarian failure. They must be given HRT in patients with gonadal dysgenesis and surgical or radiation menopause. So this is a chart which shows that if the uterus is still present, then we need a combined estrogen and progestogen. If the uterus is not there, that is hysterectomy has been done, then estrogen alone could be given to relieve the menopausal symptoms. And in case of patients with vaginal dryness or with atrophic vaginitis or some urinary symptoms, then vaginal urinary estrogen therapy is useful in women with local symptoms. So benefits are that it is very beneficial in vasomotor symptoms and urogenital symptoms, in treating sleep and mood disorders, preventing osteoporosis. It has been found that hormone replacement therapies reduces the risk of colon cancer, and it also improves the quality of life, increases libido and sexual function in the symptomatic women. So what type of HRT should be given? We have already shown the chart that HRT, depending upon if they have urogenital symptoms, we can go for local estrogen, and whether the patient has with the uterus or she is without the uterus. Without the uterus, unopposed estrogen could be given. With uterus, if she is in the perimenopausal age group, we can go for cyclical combined, and without the uterus in postmenopausal, we can go for the continuous combined. So again, HRT, again, I have already discussed, we can start the HRT in the menopause and perimenopausal age group, and any women in this age group who are experiencing menopausal symptoms. Idea is to start with the minimal dose. We have various preparations available, and it could continue, the treatment can be continued to 3 to 5 years postmenopausal or 60 years, whichever is earlier, but not beyond that. So we have estrogen preparations and we have progestrogens, though again sequential continues combined, and I will come to this in the later part of this thing. So key points is the primary use of any form of HRT is to control the menopausal symptoms and should only be prescribed for short-term relief of menopausal symptoms and prevention of osteoporosis. It should not be prescribed in the hope or expectation that it will give a protection against arterial CBD or Alzheimer's disease. And oral and non-oral estrogen have different metabolic profiles. They may have impact on side effects and therapeutic risks like venous thromboembolic risks. Next is that combined estrogen and progesterone preparations have different profiles compared to the estrogen alone, like on lipids and coronary heart disease. And increasing the breast cancer risk is related to the duration of use and also concurrent use of progestrogens. The role of estrogen and or progesterone dose is unclear. Tibolone has significantly smaller risk of breast cancer as compared to the estrogen progesterone preparation. So data on HRT associated risk should not be extrapolated to women with premature menopause. So again, I've already discussed this thing. So role of HRT is in natural menopausal symptoms in premature menopause, surgical menopause, other causes of estrogen deficiency less than 50 years, menopausal women who are at significant risk of osteoporotic fracture, and we have to consider in these patients contradiction risk very carefully. So the preparations that are available to us are the natural estrogens from plants or animal like estrogen valerate, 1 to 2 milligram preparation. We have conjugated equine estrogens and estrone. And progestins that are available in our basket are the medroxyprogesterone acetate 10 milligram, dihydrogesterone, norethistron, and norgestrel. So initial assessment is very important before starting the HRT. We have to take a history, especially the risk factors for coronary vascular disease, history of bronchial cancer, breast cancer, or the venous thromboembolism. Blood pressure has to be measured. We have to take the BMI and the lipid profile has to be done. We have to take the history of the smoking, any history of breast cancer in the family. The breast awareness screening program is important. Cervical screening is important. We have to give lifestyle advice, and we have to document and discuss the risks associated with the HRT. So systemic oral HRT, the cyclical combined we use in a perimenopausal age group, and they have monthly withdrawal bleeds. So different preparations are available. Continuous combined are available, and they should be used after 1 year if has passed after the last period. Usually the patients do not have bleed, but if the bleeding continues in some patients, then wait for 3 to 6 months. And if it continues beyond 3 to 6 months, then it needs further investigations. And unopposed estrogen, as I have already told you, it should be used only if there is no uterus. So different preparations available. Most commonly, we use the Premarin. So contraindications are that it should not be used in patients with breast cancer and endometrial cancer, in untreated endometrial hyperplasia, if there is undiagnosed vaginal bleed, if it is arterial or thromboembolic diseases, active thrombophlebitis, liver disease where the liver function tests have not returned to normal, pregnancy and breastfeeding. And if any patient is taken up for the surgery, it should be stopped 4 to 6 weeks prior to the surgery, and it should be restarted only when the patient is fully mobile. So a brief review on the postmenopausal osteoporosis. HRT is very effective in preventing the bone loss associated with the menopause, and it decreases the incidence of all osteoporosis-related fractures, including the vertebral and hip fractures, even in women not at high risk of fracture. So initiation for the sole purpose of prevention of fracture after the age of 60 years is not recommended. So once the patient has crossed the 60 years, one should not start the HRT just to prevent the fractures. So continuation of the HRT after the age of 60 years for the sole prevention of fracture should only be taken into account with possible long-term effects of specific dose and method of administration of HRT compared to other proven non-hormonal therapies. The protective effect of HRT on the BMD declines after cessation of therapy at an unpredictable rate, although some degree of fracture protection may remain after cessation of HRT. And if the patient is still considered at risk for fracture after cessation of HRT, additional therapy with proven bone-sparing medications should be given. So the risk of HRT is, again, as I've said, the endometrial cancer, the venous thromboembolic disease. Usually the increased risk have been found within 1 to 2 years of initiation of hormone therapy. Again, breast cancer, increased breast density with progestrogens via proliferation of estrogen-dependent mammary tissue, making it more difficult to detect breast cancer earlier with a mammogram. Ovarian cancer, if it has been found in more than 10 years of estrogen therapy has been given, then cerebrovascular accidents. And lipid metabolism, it has been found that there is an increased incidence of gallbladder disease following the HRT due to rise in the cholesterol in the bile. So this is the chart which shows the age related the age and the background incidence per 1,000 women in Europe not using HRT, and those who were using HRT for 5 years. This thing. So showing the chart regarding the breast cancer, endometrial cancer, ovarian cancer, venous thromboembolism, stroke, and CHT. So the HRT prescribing fell by 50% between 2001 and 2005 because of the Women Health Initiative that is in 2002, which highlighted the safety concerns. And this HRT, it really had the prescriptions really fell because of the the chart which they had given. So it raised the safety concerns. And it was found that after stopping for 5 years, the risk of breast cancer returned to the baseline. Risk of ovarian cancer also returned to the baseline after stopping for a few years. Stroke, older women have greater absolute risk of stroke on HRT. This seems to be also dose dependent. And CHT trials are on the older women, lack of evidence for younger. So overall, the risk of younger women is probably low given their already low baseline risk. So MHT, that is the menopause hormone therapy. It's a low dose oral contraceptive pills, can be given during the menopause transition and also for the premature ovarian failure till the age of menopause. And we could give only estrogen in hysterectomized patient, that is with no uterus. Estrogen and progesterone could be given in patients with uterus, I've already discussed. And then patients with subtotal hysterectomy, also they are the candidates for the menopausal hormone therapy. Patients with no uterus, past history of if there is an endometriosis. So these are the candidates for the MHT. And the commonly used regimes are the combined equine estrogen 0.6 to 5 along with medroxyprogesterone acetate 2.5, or we could go for CE plus norethistron 1 to 5 milligram tablet, or we could go for CE plus micronized progesterone or CE plus dihydrogesterone. So it could be used either in a cyclical, sequential, or continuous combined. And estrogen valerate, the 2 milligram preparation can also be used. We can also go for transdermal estrogen, that is estrabet creams plus dihydrogesterone. And this could be used in cases of cardiovascular diseases, thrombotic risk, and vaginal estrogen creams like Avalon preparations are also available in those vaginal symptoms. Then tibolone is also a drug which could be used for the menopausal symptoms, especially hot flushes and increased libido and all, and also for osteoporotic uremia, which has a weak estrogenic, progesterogenic, and androgenic property. The tibolone could be used for 2.5 milligram per day. At the same time, it has to be started after menopause, but not beyond 60 years of age. Then we have the selective estrogen receptor modulators like raloxifene 60 milligram per day or bezidoxifene 20 or 40 milligram per day preparations available. Non-oral HRT routes, that is transdermal, is indicated when if the triglyceride levels are more, CRP is more, if the patient has got a migraine, or it is a controlled hypertension, or a diabetic patient, or existing gallbladder diseases there and obesity. So in these patients, we can go for some non-hormonal, non-oral HT routes. So other supplements that should be given to the menopausal patients are the calcium, which should be given, vitamin D. Biphosphonates could be given in osteoporosis, that is the alendronate 70 milligram per week. Only thing is that the patient has to sit upright for 1 hour. Then zoledronic acid 5 milligram, which is given in the infusion form. Complementary alternative therapy, the herbal therapy could also be given where the patient is not fit for hormone therapy or patient refuses hormone therapy. Then this could be prescribed, and we have found equivalent good results. Then again, the MHT should be contraindicated in active endometrial breast cancers undiagnosed, including these patients. If a patient has got an active endometrial breast cancer, undiagnosed uterine bleeding, severe liver disease, history of venous thromboembolism, and SLE, it should not be given. Relative contraindications are migraine, thrombophlebitis, family history of CA breast, uterine fibroids, endometriosis, and the gallbladder disease. To stop HRT, if the menopausal hormone treatment, if the migraine worsens, if there is increased BP, or if there is a jaundice, and prior to any elective surgery, 4 to 6 weeks duration. So maximum duration of HT is 3 to 5 years. Maximum it could be up to 7 years, but better not beyond the 60 years of age. The general rule is when to stop HRT is after 1 to 2 years if the symptoms have gone. If they recur, we can again try for slower dose or try different method. And it should be the HRT should be stopped 4 to 6 weeks prior to major surgery. If started for early menopause, then you have to stop it at the age of 50. The side effects of HRT in the first 12 weeks is that nipple sensitivity and the breast tenderness has been found. The increase in the appetite and the patient may gain weight. The patient may complain of calf cramps. So these patients must be reviewed 6 months, then annually, for especially for the blood pressure measurement, the pelvic examination, and the breast examination. So medical alternatives like tibolone, which is a synthetic steroid, as I've already said, that it is a weak estrogenic, progesterogenic, and androgenic properties. Clonidine, it's an alpha-2 agonist which helps in vasomotor symptoms and especially useful in patients with history of breast cancer. SSRIs can reduce the vasomotor symptoms. Gabapentin, again, it reduces the severity and frequency of hot flushes. Progestogens may improve hot flushes, but there are concerns about risk of breast cancer. Riplins is a vaginal biodesic moisturizer. Clonidine enhances the effects of anxieties but should not be used with alcohol. SSRIs, the 60% relief as compared to 30% for placebo in relieving the vasomotor symptoms. And gabapentin, it reduces the frequency of the hot flushes by 45% and severity by 54%. Now, coming to the alternatives which are available in our basket in those patients who do not prefer HRT or the menopausal hormone therapy, or the menopausal hormone therapy is contraindicated, there we can go for this natural herbs and remedies. These are the phytoestrogen. The red clover structure similarity is similar to that of estradiol, and we have the data, though it is, but the data is not sufficient. And then we have black cohosh, the buttercup, it belongs to the buttercup family, flushes and for flushes and other menopausal symptoms. It is helpful, but data is not sufficient to date. Then we have progesterone creams, and then we have this acupuncture. So the plants use phytoestrogens as a part of their natural defense to control female fertility, to prevent overpopulation and overgrazing by herbivorous animals. So phytoestrogens, again, phenolics and the others which terpenoids and saponins. And the phenolics, it includes the isoflavonoids, the stilbenes and lignans. The isoflavonoids, we know the isoflavones, we are very much aware of that, and the comestans. The phenolics, other groups are flavonoids, stilbenes and lignans. Again, flavonoids are the flavones, the flavanones and the chalcones. So isoflavones, they are most common forms which are found in the soybeans, lentils, and chickpeas. That is why in the menopausal women, when their patients have, they have this hot flushes, and we usually advise them to take more of soybeans and soy products to help relieve of their hot flushes and all. So they are useful in relieving those vasomotor symptoms. So lignans, again, it's found in beans, sprouts, alfalfa sprouts, sunflower seeds, spinach, and clover. And comestans, which is present more in most cereals, fruits, and vegetables. So isoflavones effect on hot flushes, however, it is variable and inconsistent because some patients are benefited while some patients are not benefited. Only modest and delayed improvement of symptoms. And the black cohosh, again, the improvement is very modest and it's variable. So this is the chart which shows a patient with a troublesome menopausal symptoms using non-hormonal treatment. So we know that if there is a patient is coming with the vaginal symptoms, we could go for some, like locally, we could, you go for the vaginal estrogens with informed consent, and we have to consult the patients regarding some side effects like, and for breast cancer patients also in consultation with the treating oncologist. And if she is having difficulty or discomfort during sexual activity, then we can offer some silicone-based lubricants or water-based lubricants. And we can also, in severe cases, go for topical anesthetic to the vulva as 4% aqueous lignocaine. Regarding the vasomotor symptoms, we have already the non-pharmacological treatments are like cognitive behavioral therapy. It could be in the group 1-to-1 or via self-help groups, offer hypnosis, and if hypnosis is available, and we can also go for acupuncture if available. And if these are ineffective, then we go for this pharmacological treatments. And both pharmacological and non-pharmacological treatment could be used together, like anxiolytic, like escitalopram 10 milligram or citalopram 10 milligram, and we can increase the dose to 20 milligram if needed. And if ineffective or not tolerant, then we can go for venlafaxine extended release. And then if ineffective, then again go for paroxetine. And then again, if ineffective, then again we go for gabapentin. And if again that is not effective, then we can simply go to the clonidine. And then we can review these treatments depending upon the symptoms, and then we can reevaluate, and again we can go for some specialist referral if required. So hot flushes, substituting soy nuts for non-soy protein in a diet and consume 3 to 4 times throughout the day is associated with decrease in the hot flushes. Then improvement in menopausal symptoms, 25 gram of soy protein and 101 milligram of aglycon isoflavones. So lifestyle intervention to improve the quality of life during menopause. So lifestyle modifications and behavioral modification might not necessarily improve symptoms, but it can improve the sense of well-being. And we have to advise the women to maintain a healthy weight, and women must mostly request information regarding the weight gain and then menopause. And although we know that menopause does not cause weight gain, but there is evidence that weight gain can increase the severity of vasomotor symptoms. The breast cancer survivors with post-diagnosis weight gain had a greater risk of reporting hot flushes than women who did not gain weight. And one study of 40 overweight or obese women showed that 10% weight loss resulted in significant improvement in the hot flushes, with correlation between the weight loss and the reduction in hot flush frequency. So again, this is the look at the picture of this woman who is having this hot flushes. And so this is a really a very troublesome symptom, and we often get patients who are coming to us with the hot flushes, and at that time they really become depressed and helpless. So what lifestyle modification you could advise is that so we have to improve cooling through the environmental control. So small core body temperature elevations can trigger vasomotor symptoms, as I've already told that what are the triggers. So they have to avoid those tea, coffee, and spicy foods, which could trigger these vasomotor symptoms. So the suggested changes that they have to wear clothing which are made of natural fibers that breathe, and they have to go for some cotton clothes. They have to avoid fitted dresses like jumpers, and using hand fan, electric fan as required. You can keep a cooler at night, lower the body temperature, put a cold pack under the pillow, and turn the pillow over to the cool side when feeling warm. And they could use dual control electric blankets, and they could use bed fan that blows air between the sheets, and drinking cool liquids such as ice water. They usually help in improving this thing. And they have to avoid triggers, spicy foods. They have to avoid smoking, avoid control alcohol. So these are very important things to be taken into consideration. Exercise is very important because it not only helps in improving the sense of well-being and improve the quality of life, but also helps in patients with sleep patterns. It removes fatigability, improves cognitive functioning, increases bone density, and reduces the risk of cardiovascular disease. So certain yoga poses are especially effective against hot flushes, like downward facing dog and legs up the wall. So this is a beautiful diagram showing the yoga asanas. So, so there's a mixed evidence that yoga is effective for the management of vasomotor symptoms and sleep disturbance. And then group and individual cognitive behavioral therapy is also very important to improve sleep and general well-being. Paced breathing, like deep abdominal breaths where inhaling and exhaling. So they may reduce the anxiety. So relaxation exercise like hypnosis and relaxation exercise, then again hypnosis. It was found that it was more effective than an attention control comparison, and also improved sleep and hot flush if that facility is available. Then again, these acupuncture techniques, small studies have found that acupuncture as a treatment for hot flushes have shown the mixed results. And again, these magnetic therapy, reflexology, and chiropractic interventions. So the medical herbs with the following ingredients had shown very promising results. That is the Sanencum valfori, the Phlomis umbrosa, and the Angelica gigas. So the composition, that cinnamic acid 45 milligram, which is in the Sanencum valfori, S-methyl ester, the Phlomis umbrosa 41.78 milligram, the dicursin and dicursinol angelate, the Angelica gigas 45 milligram. So this estrogen preparation, which contains all of these preparations. So there is a study where cinnamic acid has shown in significant improvements in the quality of life in women dealing with the symptoms of pre, peri, and post-menopause, 2015. So it was found that that it has a significant improvement in the quality of life. Angelica gigas, the ultrafine Angelica gigas powder normalizes the women ovarian function hormone level and has osteoporosis properties in over-optimized rats. This was in 2012 study, and herbal formulation composed of this cinnamic acid and Phlomis umbrosa and the Angelica gigas nakai extracts have been used for treating menopausal symptoms. That is in 2017. So estrogen it could be used in perimenopausal, menopausal, and the postmenopausal age group. And it has been found that it downregulates the estrogen affinity to ER in reproductive target organs. So there is no proliferation of MCF7 cells in both the breast and the endometrium. So there is no risk of cancer. Whereas it upregulates the estrogen affinity to ER in the non-reproductive target organs. So in the vasoendothelium, it reduces the hot flushes and night sweats, and in central nervous system, it improves the mood swings and insomnia, and also for bone, it improves the bone marrow density. It has been found that it relieves the symptoms of vaginal dryness, hot flushes, mood swings, and bone pain, and the relief is found within 7 to 14 days. And the study concluded that had significant reduction from 10 out of 12 Kupperman index symptoms. So the evaluation of the effectiveness and safety of estrogen 100 on perimenopausal women was studied for 1 year. So this was the study which was done. And they found that osteocalcin, initially the start, it was 6.02 nanogram per ml. After 1 year, it was 5.66 nanogram per ml. So there was significant decrease. The alkaline phosphatase was also after 1 year significant decrease. And the femoral bone density, there was a significantly increase. So the study demonstrated there has been increase in the bone marrow density. So results that the estrogen 100 for 12 weeks statistically significantly improved the quality of life. 9 different symptoms improved, like hot flushes, night sweats, parenthesis, nervousness, melancholia, vertigo, fatigue, rheumatic pain, vaginal dryness of perimenopausal and postmenopausal and premenopausal women, and no adverse effects were reported with estrogen 100. And it was found to be safe and effective herbal formula that can improve women's quality of life and various menopausal symptoms. Thank you very much for your patient hearing. And now I'm open for questions.
Thank you, ma'am, for giving all this information regarding the menopausal management. So before I start with the Q&A session, I ask delegates to please post your queries in the comment section. Till then, ma'am, can I take your permission and play a video about our Shield product?
Yes, yes. Go ahead.
Thank you. Thank you, ma'am.
Should I stop sharing my slides?
No issue, ma'am.
Mm-hmm.
thank you, ma'am, for giving us time for sharing this video. So now let me ask you some questions from the delegates. So, ma'am, first question is regarding how can a woman deal with the anger management during this menopause phase?
Anger management.
Yes, ma'am.
Yeah, that mood fluctuations and all those anger management are a part of menopausal symptoms. So I have already said that the counseling, the behavioral therapy that is required, and it has been found that if we supplement with this menopausal hormone treatment and the irritability and the mood swings we have found is a significant decrease. And those patients who are not willing to take those menopausal hormone treatment, in those patients, we have found that the alternative treatments, as I already said, they work really good.
So,
So, yes.
sorry, ma'am. So do they need any counseling like
Yeah, that
psychology?
is a counseling is a bigger part. So we have to know, the once the menopause sets in, the most of the women they undergo depression, and they suddenly there is a feeling that of a loss of womanhood. So that is
So,
a very core symptom that they are suffering. So they need the upliftment of the mood. They need a reassurance not only from the doctor or the counselor, but also from the family. So the management has to be not only for the and counseling not only for the women, but for the husband, the supporting partner, whoever is with her, and they need a support, the collective counseling, so that the patient or the women they feels that everyone is with her, not only for the doctor but also with the family. So the management has to be a holistic approach. The counseling is very important, it plays an important role. So if the normal therapy, if the patient is not relieved, then we can go and refer her to some specialist for special counseling.
so with the patient as well as their family also should
Yes, yes,
have
yes.
knowledge
We
on
have
about.
found that the women usually with the anger management and all those things. If we have, I have talked with them. Usually, we get so many patients who come for to us with those mood irritability and this anger, and usually it erupt. It is like that. The once their menses ceases, then they usually all the time they are either very tired, and they are having all those dryness, and they don't feel themselves beautiful. So there is a lack of insight and lack of, the motivation is not there. And more common in those patients where these menopausal symptoms are very severe. So in those patients, the counseling not only for the patient as a support group, the husbands or the partner with whom she is living with, the supportive treatment is required. So counseling is very important. And then the treatment, obviously the treatment also is required, either with the hormonal replacement therapy or with the alternative therapy, depending upon the patient's profile.
Then, ma'am, the second question is that what do you recommend to the patients who come with the complaints like they have nightmares and very so much of sweating during night while sleeping? So, any special recommendation do you give
No,
to?
hot flushes and all those things, depending as ever, SSRIs helps. Then severe hot flushes, we have also given gabapentin also, they help. So depends upon then paroxetines. So all those SSRIs and gabapentin they help, and clonidine also it helps in severe hot flushes. But what I need to emphasize is that nightmare, and suppose if it is too much severe with your routine, this SSRIs or gabapentin or estrogen therapy, I mean, so if
Yeah.
these fail, then we have to refer for the psychiatric counseling, that whether there are any other issues which need to be looked up.
Okay. Okay, ma'am. And ma'am, any recommendation regarding diet and exercise?
Yeah, this I have already, this has been elaborately discussed in our slides. Regular exercise is a must, because not only it relieves anxiety, it also induces sense of well-being, it reduces fatigability, and then also it reduces the risk of cardiovascular disease. So exercise plays a very important role in reducing these anxiety And it also has been found that breathing exercises are excellent in these patients. So to relieve anxiety, exercise and lifestyle changes play a very important part.
Okay, ma'am. So thank you, ma'am, for giving all the answers to these questions, and also for coming on this platform and giving the important speech regarding menopausal management. And I also thanks participants for joining today's session. And we would like to have more sessions with you, ma'am, on another topics regarding gynecological department. So thank you, ma'am, for your support with us on Shield Health.
Thank you so much. Thank
Thank
you.
you, ma'am.
Thank you.
Yeah.
Bye-bye.
Thank you, ma'am. Yes.